Gastritis is simply the inflammation of gastric mucosa. However, there are several different forms of gastritis. All these forms of gastritis can be broadly categorized under two main types: acute gastritis and chronic gastritis. So, in this video, I'm going to discuss about acute gastritis. And in the next video, I will discuss about chronic gastritis. Acute gastritis is a term that encompasses a broad spectrum of entities that induce inflammatory changes in the gastric mucosa. Several different etiologies share the same general clinical presentation. We will discuss about these things in more detail in the following sections. So, before we begin our discussion on gastritis itself, we may recall some important things from our anatomy and physiology knowledge. Human stomach can be divided into 5 anatomical regions: cardia, fundus, body, antrum, and pylorus. Mucosa of the stomach contains gastric glands, which contain many types of cells, including mucus-secreting foveolar cells, parietal cells, which secrete hydrochloric acid, endocrine cells, also known as G cells, which secrete gastrin. The main function of gastrin is to stimulate parietal cells to secrete hydrochloric acid, and chief cells, which secrete digestive enzymes, including pepsin. As already mentioned, gastric acid is produced by the parietal cells, which are more concentrated in the body area of the stomach. Parietal cells secrete acid via a proton pump, which secretes one hydrogen ion into the gastric lumen in exchange for one potassium ion. This pump is denoted by the yellow arrow in this picture. Several types of substances stimulate gastric acid production by parietal cells. Each of these substances bind to their respective receptors in order to induce acid secretion. During the cephalic phase of food digestion, gastric acid secretion is stimulated by the vagus nerve. Acetylcholine is the neurotransmitter involved. Thought, sight, and taste of food are the triggering factors in this phase. And even the stress can induce gastric acid secretion in this phase. During the gastric phase, distension of the stomach and chemical substances such as histamine and gastrin induce gastric acid secretion. Gastric mucosal defense protects the mucosa from acid-induced injury. Mucus secreted by the surface epithelial cells form a continuous layer of mucus that acts as a physical barrier against gastric acid. And bicarbonate, secreted by these epithelial cells, are concentrated within the mucus layer. Bicarbonate neutralizes the back-diffusing gastric acid. Prostaglandins also play a huge role in the defense against gastric acid. Main prostaglandins secreted by the gastric mucosa are PGE2 and PGI2. They protect the gastric mucosa by reducing gastric acid secretion, stimulating epithelial cells to secrete bicarbonate and mucus, and mediating the hyperemic response that is essential to wash out excess acid. Good perfusion is also an essential component of the gastric mucosal barrier, especially to effectively remove back-diffusing ions. It also facilitates rapid healing of superficial mucosal injuries and effective transport of buffering agents. Now let's discuss about the etiology and pathogenesis of acute gastritis. Acute gastritis can be divided into 2 types. Acute erosive gastritis, which is manifested by superficial, deep, or hemorrhagic erosions, and acute non-erosive gastritis, which is generally caused by the bacterium Helicobacter pylori. Acute gastritis has a number of causes. One of the major causes is certain drugs, more specifically, non-steroidal anti-inflammatory drugs like aspirin, ibuprofen, and naproxen. Non-steroidal anti-inflammatory drugs inhibit prostaglandin synthesis in the gastric mucosa. As already mentioned, prostaglandins are an essential component of the gastric mucosal defense. Reduced prostaglandin synthesis leads to impairment of these mechanisms and back diffusion of gastric acid, leading to inflammation and erosion. Other causes of acute gastritis include acid and alkali ingestion, which causes direct damage to the gastric mucosa, alcohol, cocaine, radiation, bile reflux, ischemia, and severe physiological stress, including sepsis, trauma, burns, and intracranial lesions. I will discuss about stress ulcers in more detail in the following sections. Bacterial infection especially with Helicobacter pylori, is another cause of acute gastritis. Chronic infection with Helicobacter pylori leads to the development of acute gastritis, typically starting in the antrum, causing intense inflammation. With time, inflammation can involve the entire gastric mucosa, resulting in chronic gastritis. Helicobacter pylori is a rod-shaped, mottled bacterium that lives beneath the gastric mucus layer, attached to epithelial cell surface. How the bacterium is transmitted is not entirely clear, but it is likely from person to person through fecal-oral route and through the ingestion of contaminated water and food. This is why the prevalence of Helicobacter pylori infection is higher in low socioeconomic regions and in developing nations. Several virulence factors of Helicobacter pylori help the organism to withstand the gastric acidity and induce gastric mucosal inflammation. Flagella enable bacterial motility and chemotaxis to colonize under the mucus layer. Adhesion molecules enable the successful anchorage of the organism to epithelial surface. The ability to withstand gastric acidity is due to the secretion of very potent Urus enzyme. This enzyme hydrolyzes urea in the mucus layer and produces ammonia, which neutralizes the back-diffusing gastric acid. This makes the bacterial microenvironment neutral. The bacterium also secretes other enzymes, including mucinous, protease, and lipase, that cause gastric mucosal injury. It also secretes exotoxins, mainly the vacuolating toxin, also called VAC-A, which causes gastric mucosal injury. Moreover, Helicobacter pylori secretes effectors, mainly CAG-A, which causes actin remodeling, induction of interleukin-8, and host cell growth inhibition. In addition to direct mucosal injury, these factors also induce recruitment of leukocytes to the sites, which contributes to the inflammatory process. CAG-A and VAC-A positive strains of Helicobacter pylori are more virulent and cause severe inflammation, severe disease, and associated complications. Helicobacter pylori has been identified as a carcinogenic bacterium due to its strong association with gastric carcinoma and lymphoma. Infection with cytomegalovirus is another rare cause of acute gastritis. And fungal infections, like candidiasis and histoplasmosis, can also cause gastritis rarely. Phlegminus gastritis is an uncommon form of acute gastritis caused by numerous bacterial agents, including Streptococci, Staphylococci, Proteus species, Clostridium species, and E. coli. Phlegminus gastritis usually occurs in individuals who are debilitated. It is associated with a recent large intake of alcohol, concomitant upper respiratory tract infections, and acquired immunodeficiency syndrome. In Phlegminus gastritis, infection spreads to the deeper layers of the stomach, leading to purulent inflammation, followed by gangrene. The clinical diagnosis is usually established in the operating room, as these patients present with an acute abdominal emergency requiring immediate surgical intervention. Without appropriate therapy, Phlegminus gastritis can progress to peritonitis and death. Now let's discuss a bit about stress ulcers. As already mentioned, stress ulcers occur in conditions like severe trauma, burns, sepsis, intracranial disease, and other serious medical illnesses. Ulcers occur in the proximal duodenum associated with severe burns or trauma are called curling ulcers. Gastric, duodenal, and esophageal ulcers that occur in patients with intracranial disease are called Cushing ulcers. Pathogenesis of stress ulcers is most often related to local ischemia. Here what happens is that stress-induced splanchnic vasoconstriction leads to reduced blood flow to the gastric mucosa, resulting in ischemic injury. Lesions associated with intracranial injury are thought to be caused by direct stimulation of vagal nuclei that causes hypersecretion of gastric acid. Now let's discuss about the clinical features of acute gastritis. Patients with acute gastritis may experience gnawing or burning epigastric distress, sometimes accompanied by nausea and vomiting. The pain may improve or worsen with eating. Other symptoms are usually due to complications associated with acute gastritis. Some of these complications include the following: bleeding from an erosion or ulcer, gastric outlet obstruction due to edema, dehydration from vomiting, renal insufficiency as a result of dehydration, and gastric perforation and peritonitis. Now let's discuss about the diagnosis of acute gastritis. Obtain the following information and history if possible. Presence of a previous mucosal injury, such as gastritis, peptic ulcer disease, or any endoscopic or surgical injury, history of eating raw fish, exposure to potentially noxious drugs or chemical agents, and routine use of aspirin or other non-steroidal anti-inflammatory drugs. Endoscopy and biopsy are considered the gold standard methods in making the diagnosis, identifying disease severity, distribution, and the cause. Radiologic findings also helpful in making the diagnosis. Four major radiologic findings are thick mucosal folds, inflammatory nodules, coarse area gastrica, and erosions. Laboratory studies are not significant in diagnosing gastritis but may help with the diagnosis. A complete blood count may be required to assess anemia due to bleeding from ulcers. In women, ruling out pregnancy is important in the diagnosis. In addition, liver and kidney function tests, gallbladder and pancreatic function tests, and stools for blood are also important. For the diagnosis of Helicobacter pylori infection, both non-invasive and invasive methods are available. One of the widely used non-invasive methods is Urus breath test, where the patient is given a urea-containing meal. In this meal, urea contains radioactive carbon. If Helicobacter pylori is present, it will break down urea into ammonia and carbon dioxide. This carbon dioxide is now radioactive and can be detected when the patient exhales. Serology for anti-Helicobacter pylori IgG is another non-invasive method. However, it cannot differentiate between the active and past infections. But Helicobacter pylori antigen test on stools can identify the active infection. Invasive methods are based on demonstration of the organism on endoscopic gastric biopsies. Urus test on gastric biopsies, also known as the CLO test, is one of the main ones. CLO kit contains urea and a pH indicator. Endoscopic biopsies are put on the CLO kit and if Helicobacter pylori is present, it will break down urea and produce ammonia, and then the medium will become alkaline. This can be detected by a color change in the medium. Culture of the Helicobacter pylori organism has a high specificity, however it is not done routinely. Histology is also useful in identifying the organism, commonly with H&E stain. However, the specificity can be improved with special stains, such as modified Giemsa and Warthin Starry silver. Finally, let's discuss about the treatment of acute gastritis. Over-the-counter drugs such as antacids and sucralfate, histamine receptor antagonists such as cimetidine and famotidine, and proton pump inhibitors such as omeprazole can stabilize mild to moderate cases in short term. However, in long-term management, you need to treat the underlying cause. This may include avoiding non-steroidal anti-inflammatory drugs, caffeine, and alcohol, quitting smoking, eradication of Helicobacter pylori, etc. Eradication of Helicobacter pylori is extremely important in the long-term management of acute gastritis. First-line treatment includes either with bismuth quadruple therapy or clarithromycin-based triple therapy. Quadruple therapy includes bismuth, a proton pump inhibitor, and nitroimidazole, and tetracycline for 10 to 14 days. Triple therapy includes amoxicillin or imidronidazole, a proton pump inhibitor, and clarithromycin for 10 to 14 days. Second line, or salvage therapy, depends on the antibiotics used in the first course of treatment, and culture results in cases of resistant strains. Other management measures include fluid and electrolyte replacement if the patient is vomiting and dehydrated, and treatment for complications. In case of Phlegminus gastritis, surgical resection of the affected part is essential. Okay. That is all I wish to discuss in this video. Hope it made sense. If you have any question or doubt regarding this topic, feel free to post them in the comment section. Thanks for watching. See you soon in the next video.